Hello, in this session we shall discuss odontogenic cysts and we shall be looking at the classification of jaw cysts, the origin and pathogenesis of jaw cysts, uh, general signs and symptoms, uh, diagnosis, and then we shall discuss some of the more common odontogenic cysts in detail, including radicular cyst, dentigerous cyst, and odontogenic keratocyst. A cyst may be defined as a pathological cavity which is usually lined by epithelium and contains fluid, semi-fluid, or gaseous material other than pus. Obviously, if a pathological cavity contains pus, uh, it may be more appropriate to label it as an abscess. Equally, it's important to recognize that pre-existing cystic lesions may also develop suppuration when they get infected. So abscess formation within the lining of cysts is also quite common, especially with radicular cysts. Uh, as mentioned, classically the cystic lining is composed of epithelial tissue, but you would also encounter cystic lesions in the head and neck region where the lining is not epithelium, but it may be granulation tissue or bone. But classically, a cyst is a pathological cavity lined by epithelium and containing fluid, but there are some exceptions as we shall learn in the later part of the session. Broadly speaking, cysts of the oral and maxillofacial region are classified as odontogenic and non-odontogenic. Odontogenic cysts include developmental as well as inflammatory cysts, whereas the non-odontogenic cysts include fissural cysts, bony cysts, as well as soft tissue cysts. Odontogenic cysts develop from tissues involved in tooth development, and the first variety of developmental odontogenic cysts include cysts developing from remnants of dental lamina, and this type includes odontogenic keratocyst, calcifying odontogenic cysts, lateral periodontal cysts, and gingival cysts of adults and newborns. The second variety of developmental odontogenic cysts develop from remnants of reduced enamel epithelium and include dentigerous cyst as well as eruption cyst. Basically, eruption cyst is a dentigerous cyst which is localized to the soft tissues, whereas the dentigerous cyst develops within the jawbone. And finally, the second variety of odontogenic cysts is the inflammatory cysts, and the most recognized one is periapical or radicular cyst, which develops from remnants of epithelial cell rests of molasses. And this is one cyst which all of you are likely to encounter in general practice. Non-odontogenic cysts are not going to be discussed in this session, but we shall briefly review the classification of non-odontogenic cysts. So the first type are the fissural type of non-odontogenic cysts, which develop as a result of entrapment of epithelium along the paths of fusion of embryonic processes and include the incisive canal or nasopalatine cyst. This is one of the most common type of fissural cyst which presents in the jawbone. Also nasoalveolar or nasolabial cyst, and then palatal cysts of the newborn, including Epstein pearls and Bond's nodules, are a type of non-odontogenic fissural type cysts. And then you would also find mention about median palatal cysts, globulomaxillary cysts, and median mandibular cyst in the literature, but their existence is controversial, and this can be discussed when we talk about non-odontogenic cysts. The other type of non-odontogenic cysts include primary bone cysts, which are not lined by epithelium, but they're lined by uh, the jawbone and include aneurysmal bone cysts, solitary bone cyst, which is also known as simple or traumatic bone cyst, and finally Stephane's idiopathic bone cavity, which results from entrapment of salivary gland tissue in the jawbone. And finally, the third variety are soft tissue cysts and include salivary cysts. Salivary cysts are of two types: mucus retention cysts, which are lined by epithelium, and extravasation cysts, which are lined by granulation tissue. And it's the extravasation phenomena which leads to one of the most common types of soft tissue cysts in the oral cavity and the lips, which we call mucocele and granula. And finally, we also have thyroglossal tract cysts, benign lymphoepithelial cysts, and dermoid and epidermoid cysts. All of these occur in the soft tissues and are of the non-odontogenic variety. Looking at the relative frequency of jaw cysts, odontogenic cysts are more common, and 65% of these are dental or radicular cysts, which develop as a complication of pulp necrosis and spread of infection into the periradicular tissues. Dentigerous cyst is the next common developmental odontogenic cyst and constitutes about 20% of jaw cysts. The third variety is odontogenic keratosis, which accounts for about 5% of jaw cysts. So all three cysts, that is the radicular, dentigerous, and odontogenic keratosis, they develop within the jawbone. Non-odontogenic cysts, the most common one and recognized one is the nasopalatine cyst, which develops in the anterior maxilla, whereas all other non-odontogenic cysts combined account for only 5% of jaw cysts. So in other words, we can see you're most likely to encounter either a radicular cyst or a dentigerous cyst in general practice settings. Uh, and of the non-odontogenic variety, the most common one is the nasopalatine cyst. Before discussing individual odontogenic cysts, it would be useful to review the general signs and symptoms associated with cysts. So cysts could be asymptomatic, especially if they are of a small size. Pain and swelling generally develops when the cysts get infected, and they may be accompanied by uh, infection may be accompanied by foul taste due to discharge of fluid from the cystic lining. An impacted tooth may be associated with a dentigerous cyst, while a missing tooth may be associated with a keratosis, and we'll understand uh, this more when we discuss the pathogenesis of dentigerous and keratosis. Pathological fractures may be associated with large cysts which encroach on the lower border of the mandible. Displacement and loosening of teeth is also associated with a variety of cysts, particularly um, dentigerous and radicular cysts. Discoloration of a tooth might be indicative of loss of vitality and is especially recognized with uh, radicular cysts. And finally, discomfort under a denture might be the initial presentation of uh, a dentigerous cyst or a residual cyst in the jawbone. During clinical assessment, the following signs may be associated with cystic lesions of the jaw: swelling, jaw expansion, particularly with infected cysts; soft tissue changes such as development of a sinus tract or a parallus. Tooth involvement may manifest as missing teeth, impacted teeth, as discussed in the previous slide; loss of vitality, particularly with radicular cysts; loosening, displacement, or malalignment of teeth; and changes in percussion note. In addition, cystic lesions of the jaws may present with nerve involvement. For example, a large radicular or dentigerous cyst in the mandible molar area may present with paresthesia or anesthesia of the inferior alveolar nerve. Uh, Cystic lesions also present with evidence of fluctuance. Uh, Infected cysts may also present with a sinus tract, and with maxillary cysts in the molar premolar area, which involve the maxillary antrum, may present with signs of maxillary sinusitis. Distortion of the nostril may be seen with soft tissue cysts such as the nasolabial cyst. Radiography is one of the most valuable tools used in the recognition and diagnosis of jaw cysts. Appropriate radiographs and CT scan images uh, can provide the outline, the extent and morphology of the lesion, whether the lesion is uh, circular, ovoid, or irregular, and the size and extent of the lesion. They would also show you the relationship of the lesion with the teeth, and also the relationship of the lesion to other anatomical structures such as the floor of the nasal cavity, the floor of the maxillary antrum, uh, involvement of the orbital floor. Similarly, in the mandible, uh, the relationship of the lesion with the inferior alveolar canal, and also the lower border of the mandible. Uh, in soft tissue cysts, the outline may be demonstrated by injection of a contrast medium prior to radiography. So if you are dealing with purely soft tissue lesions, they might not show appropriately on radiographs unless you inject a contrast medium prior to the radiographs, and then even soft tissue lesions would show up on appropriate radiographs. Many odontogenic cysts are asymptomatic in the initial stages and are recognized on routine radiographs such as periapical radiographs or OPGs taken for other reasons such as diagnosis of impacted third molars or periradicular disease. In addition, you can also use occlusal radiographs to determine the buccolingual extent of cystic lesions in the jawbone, and occipitomental views or paranasal sinus view for cysts involving the maxillary sinus. Obviously, this would be done in secondary care settings. You don't have this facility available in primary care dental surgeries. And finally, large cysts involving either the maxillary antrum, the orbital floor, the nasal cavity, or the uh, inferior alveolar nerve in the mandible. uh, there may be a need to undertake cone beam CT for a more detailed and comprehensive view of the extent of cystic lesions in the jawbone. In addition to radiographs and cone beam CT, aspiration of the uh, cystic lesion can provide valuable information. So you can use a 10 or 15 cc disposable syringe, stick it into the cystic lesion and aspirate. And the nature of the aspirate can provide a lot of useful information. So for example, if you were to aspirate pus from a cystic lesion, it might indicate suppuration and abscess formation. Presence of blood in the aspirate might indicate a vascular malformation. Presence of air may be indicative of uh, the lesion involving the maxillary antrum. A straw-colored fluid is usually aspirated with radicular cysts, while with the odontogenic keratosis, you might aspirate a thick white sludgy fluid. And finally, if you are unable to aspirate anything, or if the aspiration is negative, it might imply that the lesion is not cystic and may actually be a solid lesion like a tumor. Culture and sensitivity is usually not done for cystic lesions, but if the cyst is infected, and there are clinical signs of infection, um, the aspirate may be submitted to the laboratory for culture and sensitivity to determine the nature of microorganisms involved in uh, the infected cyst as well as their sensitivity to different antibiotics. In addition, biochemistry of cystic aspirate may be undertaken, but is generally reserved for research purposes only. One of the most common biochemical tests which can be performed is estimation of soluble proteins in the cystic fluid. Keratocysts generally have a soluble protein content of less than 4 grams per deciliter, whereas other cystic uh, lesions and cystic tumors generally have a soluble protein content of greater than 5 grams per deciliter. However, presence of infection and inflammatory exudate, uh, the proteins present in the inflammatory exudate can influence the results. Biopsy remains the gold standard tool for definitive diagnosis of cystic lesions. Incisional biopsy is indicated for lesions in the mandibular ramus and angle area or for extensive lesions encroaching on vital anatomical structures and where there is a suspicion of a potentially neoplastic lesion. You would take a small piece of tissue from the lesion and submit it for biopsy, um, and then you would plan your definitive treatment. Uh, Excisional biopsy is warranted for all lesions removed surgically. So whether they are small lesions which are removed uh, in a single stage or for large lesions which have been initially diagnosed with an incisional biopsy, once you enucleate them at a later stage, you would submit the surgical specimen for biopsy again to confirm your diagnosis and also to confirm that the lesion has been removed completely. Having discussed some of the general features of odontogenic cysts, we can now talk about individual odontogenic cysts, starting with radicular cyst, which is the commonest type of odontogenic cyst of the oral cavity and accounts for up to 54% of periapical radiolucencies. The origin of radicular cyst uh, usually uh, following pulp necrosis, there is spread of inflammation into the periradicular tissues, uh, and at this stage, uh, it may manifest as apical periodontitis when the tooth is tended to percussion, followed by development of a dental abscess, which may present with a draining sinus. If it remains untreated, persistent inflammation may lead to development of a periapical granuloma. And a persistent periapical granuloma may initiate an inflammatory response to stimulate epithelial cell rests of malaces in the periradicular tissues, and it is the rest cells of malaces which provide the lining for the cystic transformation of a periapical granuloma. Uh, in terms of clinical presentation, obviously the affected tooth might have evidence of caries or trauma, and there might be a history of pulpitis previously. A radicular cyst may present, uh, may be asymptomatic at the time of diagnosis and may be diagnosed on routine periapical radiographs, or it may present with signs of acute infection such as pain, swelling, a discharging sinus, tooth mobility, etc. There are three main types of radicular cysts. Apical is the most common, where the radicular cyst is localized to the root apex. Sometimes it may be in a lateral location, especially if there are lateral canals present in the root apex. And the third variety is the residual type of radicular cyst, which develops at the site of a tooth extraction. Following tooth extraction, if the radicular cyst is left in situ and is not removed, that is what we call a residual cyst, and we shall talk more about it. Radiographically, radicular cysts present as well-defined radiolucent areas around the root apex, and there is loss of lamina dura. The size can be highly variable. They may be as small as a centimeter in diameter, or sometimes they may be quite large, as you can see in this particular image. Uh, Root resorption is common because it's an inflammatory type of cyst, and inflammation on the external aspects of the roots may lead to root resorption. Uh, the appearance is very much identical to a granuloma and not conclusive. So whilst uh, a larger periradicular lesion might be indicative of a cystic lesion, it is inappropriate to differentiate between periradicular cysts and granulomas purely on radiographs, and this definitive diagnosis should be based on uh, a biopsy, which will give you a more definitive diagnosis. So when you see periradicular radiolucencies, it's best to label them as periapical pathology. Whether it is a cyst or a granuloma would be more clear following a biopsy. The commonest site for development of radicular cysts are either the uh, first molars, which are uh, most affected by caries because they are the first teeth to erupt in the permanent dentition, and you can see a large periradicular radiolucency associated with the roots of a carious lower right first molar. And the second commonest site are the maxillary anterior teeth, which are most commonly affected by trauma. In addition to solitary lesions, you may encounter patients who present with multiple radicular cysts. As you can see on this OPG image, there are multiple radicular cysts involving the right mandible body. Similarly, the left mandible parasymphysis and body region, you can see multiple cysts, and perhaps there are more in the maxilla, even though the quality of the radiograph doesn't show them very clearly. So you can clearly see multiple decayed teeth and a compromised dentition, which has led to the development of multiple radicular cysts. This radiographic image depicts a large radiolucent lesion involving the lower right premolar region and represents a residual cyst, which is a type of radicular cyst which develops following extraction or removal of the uh, involved tooth. So the involved premolar probably had a periapical lesion which was left in situ and which developed and expanded further uh, during the course of the post-operative post-extraction phase, and this is what we call a residual cyst. So this is also a type of radicular cyst, but it develops at the site of removal or extraction of the offending tooth. This image shows an extracted tooth with multiple cystic lesions attached to the root apices, and if the radicular cysts are small and there is considerable bone loss around the roots, it is not unusual for the clinician to be able to extract the tooth along with the uh, periradicular lesions. In any case, you should correlate uh, this with the preoperative radiograph, and if there is evidence of a periradicular radiolucency uh, associated with the root apex of a tooth and the lesion does not remain attached to the tooth when you extract it, it is important that you curate the socket and remove the uh, a cystic lesion in the base of the socket. Otherwise, it may manifest later as a radicular cyst. Microscopically, radicular cysts are composed of a cystic lining consisting of stratified squamous epithelium, and the epithelial cells desquamate into the lumen, filling it with necrotic debris and protein-rich fluid. Uh, Adjacent to the epithelial lining is a fibrous connective tissue wall, which may show mixed inflammatory cell infiltrate. Epithelium may also show Rushton bodies, which are linear arc-shaped calcifications, and the lumen, the wall, or both may contain evidence of dystrophic calcifications, cholesterol clefts, and RBCs and hemosiderin pigmentation, as we shall see in the histopathological image on the next slide. This low-power histopathological image from a radicular cyst shows the lining of the cyst composed of stratified squamous epithelial cells. This is the lumen of the cyst where the uh, necrotic epithelial cells desquamate and fill the lumen, and you can see the connective tissue wall where the blue dots represent chronic inflammatory cells and the spaces represent the cholesterol clefts because fat is lost during preparation of histopathological sections and appears as empty spaces. So this is the classical picture of a radicular cyst. The important thing is that you recognize the lining, the connective tissue wall, and the lumen of the cyst. Dentigerous cyst is the commonest type of developmental odontogenic cyst and accounts for approximately 20% of jaw cysts. In terms of the origin, uh, dentigerous cyst usually develops in relation to impacted teeth, so most commonly seen in association with wisdom teeth as well as the maxillary canines, which are the most commonly impacted teeth in the oral cavity. And in terms of the pathogenesis, uh, because the teeth fail to erupt, the reduced enamel epithelium persists, and if there is fluid accumulation between the reduced enamel epithelium and the crown of the tooth, that may lead to development of a dentigerous cyst. So the epithelial lining is provided by the reduced enamel epithelium, and it usually develops in relation to impacted wisdom teeth or impacted maxillary canines. In terms of clinical presentation, small dentigerous cysts may be asymptomatic, but when they get secondarily infected, they may present with signs of acute inflammation such as pain, swelling, discharge, etc. Radiographically, dentigerous cyst usually presents as a well circumscribed unilocular radiolucent lesion associated with the crown of an unerupted tooth. With large cysts, there may be a pseudo impression of multilocularity because uh, as the cyst enlarges and resorbs bone, some of the bony trabeculae may persist and may give a pseudo impression, a false impression of multilocularity. Uh, Generally, dentigerous cysts are well defined and may have a sclerotic border, but infected cysts may show ill-defined borders. Sometimes it's difficult to differentiate between an enlarged follicle around an impacted tooth and a dentigerous cyst, and the general guidance is that cystic transformation should be suspected if the pericoronal radiolucency is more than 4 millimeter in diameter. So this image depicts a classical dentigerous cyst around an impacted mandibular third molar on the left side, and you can see a large pericoronal radiolucency associated with an impacted tooth, and you may put your money on a dentigerous cyst in this situation because that's the most likely cause. There are three main radiographic varieties of dentigerous cyst. The classical central variety, where you see pericoronal radiolucency uh, around the crown of a partially erupted or impacted tooth. The lateral variety, where the radiolucency is in a lateral location. And finally, a circumferential variety, where the cystic lesion completely envelops the tooth. That's known as the circumferential variety. Other features of dentigerous cysts are displacement of teeth and root resorption, particularly with infected cysts where there is significant inflammation. It is not unusual to see significant root resorption of the adjacent teeth. This radiograph shows a classical central variety of dentigerous cyst where you see a pericoronal radiolucency, unilocular radiolucency around the crown of an unerupted wisdom tooth. So this is the central variety. This sectional OPG shows a unilocular radiolucency which is lateral to the impacted wisdom tooth, and this is what we call the lateral variety of a dentigerous cyst. And finally, this radiographic image shows a large unilocular radiolucency which completely surrounds the impacted wisdom tooth, and this is what we call the circumferential variety of a dentigerous cyst. Also remember that there could be several complications associated with a dentigerous cyst, including development of an ameloblastoma in a dentigerous cyst, squamous cell carcinoma, and mucoepidermoid carcinoma. This sectional OPG shows a large dentigerous cyst associated with an impacted left mandibular third molar, and you can see that the cystic lesion presents as a unilocular radiolucency which extends from the angle area all the way to the uh, lower left 5, and it also involves the lower border of the mandible. Probably there is some discontinuity at the lower border of the mandible which may contribute to development of a pathological fracture. And you can also see the shadow of the inferior alveolar canal. So this cyst involves the inferior alveolar canal, and the patient may present with signs of uh, numbness on the lower lip and the chin. So this is another type of circumferential dentigerous cyst, uh, possibly associated with a pathological fracture or discontinuity at the lower border of the mandible on the left side. And it is not unusual to find dentigerous cysts associated with impacted maxillary canines, and you can again see a large pericoronal radiolucency associated with an impacted uh, right maxillary canine. And you might want to think about the treatment options for this tooth. I'll leave you to wonder about that, and maybe we can discuss it separately in another session. Histopathologically, dentigerous cysts might be uninflamed or inflamed. So if you look at a non-infected, uninflamed dentigerous cyst microscopically, uh, obviously you would have an epithelial lining and a connective tissue wall. When the cyst is uninflamed, you might see a loosely arranged fibrous connective tissue wall with small islands of inactive appearing odontogenic epithelial rests, and the epithelial lining itself consists of 2 to 4 layers of cuboidal epithelium, and the epithelial connective tissue interface is flat, as we shall see in the next slide. This microscopic image shows a low power section from a dentigerous cyst. You can see the connective tissue wall, a loosely arranged fibrous connective tissue wall, and an epithelial lining consisting of uh, 2 to 4 layers of cuboidal epithelial cells, and you can see the epithelial connective tissue interface is flat. This would be the lumen of the cyst. You can see some of the epithelial cells shedding, desquamating and shedding into the lumen of the cyst. So this is a low power section from an uninflamed cyst where the epithelial connective tissue interface is flat. You don't see any inflammatory cells in the connective tissue wall. So these are some of the features of dentigerous cyst when there is no inflammation. If a dentigerous cyst develops inflammation due to infection, there would be several changes observed. Firstly, the connective tissue wall will show increased collagenization and it would become thicker. Secondly, there would be infiltration of chronic inflammatory cells in the connective tissue wall, and there would be uh, evidence of epithelial hyperplasia, uh, development of rete ridges between the epithelial lining and the connective tissue wall, and also squamous features. So the cuboidal lining may change into squamous variety following inflammation in a dentigerous cyst, as we shall see in the next image. So this image shows an inflamed dentigerous cyst. So this is the lumen of the cyst, this is the epithelial lining, and this is the connective tissue wall. And you can see the connective tissue wall is much thicker and there is presence of chronic inflammatory cells in the wall. And also you can see development of rete ridges between the epithelium and the connective tissue. And so these are some of the key features you should note in an inflamed dentigerous cyst. So the classical dentigerous cyst we discussed in the previous slides is intraosseous. That means it develops within the bone. Sometimes what can happen is that the cystic transformation only takes place whilst the tooth is close to eruption, and if the overlying gingival tissue is particularly fibrous and thick, the tooth may fail to erupt and the reduced enamel epithelium may undergo a cystic change, and that is when we call it an eruption cyst because it is localized only to the soft tissues. Hence, eruption cyst is a soft tissue counterpart of classical intraosseous dentigerous cyst, and it develops due to separation of dental follicle from the crown of an erupting tooth that is within the soft tissues, and it may present as a swelling with a bluish tinge uh, around an unerupted tooth, and the treatment is fairly straightforward. A small nick in the gingival tissue with a scalpel will drain the fluid and allow the tooth to erupt. Although much less common than uh, a radicular or a dentigerous cyst, keratocysts are well recognized type of odontogenic cysts which occur in the jawbone. The origin of a keratocyst, it develops through degeneration of the tooth primordium. So if a tooth primordium degenerates and undergoes cystic changes, you would expect a missing tooth unless this phenomena develops in relation to a supernumerary tooth. So with keratosis, it is not unusual to have a missing tooth due to degeneration of the tooth primordium. And based on the origin, the other name of a keratocyst is a primordial cyst because it develops after degeneration of a tooth primordium. The term keratocyst mainly relates to the histopathological features of this cyst, which we shall discuss in a minute. The most common site is the posterior mandible, the body and the angle area, and also the posterior maxilla. Other areas of the jaws may be involved with lesser frequency. In terms of presentation, small keratocysts may be asymptomatic and may be diagnosed Incidentally, when radiographs are taken for uh, other purposes, whereas large lesions may present with infection and inflammation, and again you would notice the classical signs of inflammation as we've discussed with other types of cysts. The classical radiographic appearance of a keratocyst is a multilocular lesion, uh, multilocular radiolucent lesion, and you can see on this OPG that there is a large multilocular lesion extending from the left mandibular ramus all the way into the angle and the body of the mandible up to the distal root of the lower first molar. And you can also note that the third molar is missing on this occasion because the cyst has probably developed from degeneration of the tooth primordium for the wisdom tooth. And what you would also note is that the cyst involves the inferior alveolar nerve, and you would expect that this patient may have evidence of numbness on the lower lip and the chin area. Uh, so this is the classical presentation of a keratocyst multilocular radiolucency. In addition to keratocysts, several other lesions may present as multilocular radiolucencies in the posterior mandible. The list is pretty long, but I'll just name a few. You could have a similar presentation with an ameloblastoma, a calcifying epithelial odontogenic tumor or Pinbog tumor. Similarly, odontogenic myxomas are also multilocular, central giant cell granulomas, aneurysmal bone cyst, traumatic bone cyst, intraosseous carcinoma, lesions are related to multiple myeloma. So all of them can present as multilocular radiolucencies in the posterior mandible, and it is important that you recognize these lesions when you're developing your differential diagnosis. Histopathologically, keratocysts present with some unique microscopic features, and this is the basis for the term keratosis. The connective tissue wall of keratosis is classically quite thin and friable and is difficult to enucleate because as you may try to enucleate the cyst, the thin friable wall may uh, separate and make enucleation difficult, and this is one reason for the high recurrence rate for keratosis. The epithelial lining consists of a uniform layer of stratified squamous epithelium, which is 6 to 8 cells thick. If the cyst is uninflamed, the epithelial connective tissue interface would be flat and the retiridges would not be conspicuous. However, if inflammation develops in the cyst, the epithelial connective tissue interface may develop conspicuous retiridges. The luminal surface of the cyst shows parakeratotic epithelium, and the basal cell layer shows palisading. That means that the basal cell layer of the epithelial lining, the cells lie at the same level. So basal palisading, thin connective tissue wall, and parakeratotic luminal surface of the epithelium are some of the classical features of a keratocyst when you view it under a microscope. So this high power section from a keratocyst shows some classical features we discussed in the earlier slide. You can see the epithelial lining consists of 4 to 6 layers of stratified squamous epithelium, and the uh, topmost layer towards the lumen consists of partially degenerated nuclei, so parakeratosis, and the epithelial connective tissue interface is flat because it's an uninflamed cyst, so the retiridges are not prominent. You do not see any inflammatory cells in the connective tissue wall, and you can also observe basal palisading, that the basal cell layer of the epithelial lining, the cells lie at the same level. So it's also known as tombstone appearance. So parakeratotic luminal surface, basal palisading, and flat epithelial connective tissue interface are some of the classical microscopic features of a keratocyst. And you can see the lumen shows shedding of epithelial cells into the cavity. Other histopathological features of keratosis include presence of satellite cysts or daughter cysts, which may be present in the connective tissue wall, and the lumen may contain a clear liquid composed of transudate of serum or a cheesy material, which is basically keratinaceous debris from shedding epithelial cells into the lumen. So this is a histopathological section from the connective tissue wall of a keratocyst, and you can see multiple daughter cysts present in the connective tissue wall, and they may also account for the high recurrence rate of a keratosis. So the thin connective tissue wall, accompanied by presence of daughter cysts, is responsible for the high recurrence rate of keratosis, and this is probably one of the reasons why uh, a few years ago keratocysts were labeled as odontogenic keratocystic tumor. However, my understanding is that this terminology has been abandoned and now we still use the term odontogenic keratocyst. When describing odontogenic keratosis, it's common to discuss the Gorlin-Colt syndrome, which is inherited as an autosomal dominant trait and presents with multiple basal cell carcinomas of the skin, multiple jaw cysts of the keratosis variety, rib anomalies, vertebral anomalies, as well as intracranial calcifications. These images show manifestations of Gorlin-Colt syndrome, including intracranial calcifications, multiple basal cell carcinomas of the skin, rib anomalies. You can notice bifid ribs at multiple points, and also multiple jaw cysts involving the right side of the mandible as well as the left side, and also the right maxillary canine region. And finally, we can talk about some of the least common types of odontogenic cysts, such as the gingival cyst of the adult, which develops in the soft tissues of the gingivae from remnants of dental lamina. Another uncommon variety is a developmental periodontal cyst, which originates from proliferation of dental lamina remnants in the jawbone. And as you can see, uh, it presents as a unilocular radiolucency in a lateral location in relation to the involved teeth. Uh, Obviously, the involved teeth would be vital uh, with a developmental periodontal cyst, and the commonest location is the lower premolar area. Although uncommon and rare, perhaps rare, it's important to recognize the existence of developmental gingival cysts of the adult as well as the uh, uh, developmental periodontal cyst. In summary, you should develop an understanding of different types of odontogenic cysts, their origin, clinical and radiographic presentation, as well as histopathological features. And it might be best to focus on the common types of odontogenic cysts such as radicular cyst, dentigerous cyst, and also keratosis. And in the subsequent stages of the program, you will also be learning about the treatment options for these cysts.